and I welcome you all in this conference. Today's first session is the session of the Industry Symposia that is organized by the Nabi Qasim Pharmaceuticals. And this symposia is on a very important talk that is on the diabetes. Type 2 diabetes challenges in the new era. What our primary care physicians need to know. This is a very important topic. And for this, I would like to call on the stage our worthy panelists. Among them, we have Dr. Sarwar Malik. He is the consultant endocrinologist and head of department of CDA Hospital, Islamabad. The next panelist is Dr. Azra Rizwan. Dr. Azra Rizwan is the consultant endocrinologist at Aga Khan University Hospital. She is the executive member of the Pakistan Endocrine Society and leads the CHAMPS project. This is for the prevention of the diabetes among children. The third panelist is Dr. Sumerah Jabeen. She is the consultant endocrinologist at Indus Hospital, Karachi. She is also the leading project of the endocrine in her hospital. Now, it is a time and the introduction of our worthy panelist, Professor A.H. Aamir. Sir is the consultant endocrinologist and head of department of the Peshawar General Hospital. He is the past president of Pakistan Endocrine Society, Clinical Endocrinology of American Society, and he is the president-elect of Southeast Asian Federation Endocrine Societies. Sir, you are welcome on the stage for your insightful talk.
Right. Thank you very much for kind introduction. These days, anyone would like to be president of American Association, but I am not. I was the president of American Association Pakistan chapter. So, but surprisingly, anybody who's recently been to US, they said that anything short of coming down and hugging a Pakistani, they have done everything. So that's a good news for us. So I'll be talking about a topic which probably everybody is aware, but I thought I'll just change it. What does our primary care physician need to know? And I'll be talking about the challenges and what we come across and what our primary care physicians come across. Just to start off, diabetes is rampant. To me, the most important part is undiagnosed, and keep a high threshold for this undiagnosed part, because it has got relevance, and I'll tell you relevance later, that why this part is important. Everybody knows a lot of diabetes in Pakistan, 1 and 3, rank 4 will become 3 and 2 and whatever. But I will concentrate here that about 26 or 27% of people with diabetes are undiagnosed. Keep that in mind, and I'll touch that in a minute. We all know that there are modifiable risk factors and then there are non-modifiable risk factors. Don't want to go into details of what are the modifiable and what are non-modifiable risk factors, but I think these are the things which, from public health perspective, we need to look into. We cannot change our parents. We cannot change what the maternal fetal programming is. But of course, maternal and fetal health is important. But I think these are modifiable risk factors. And regardless of what treatments do we have, regardless of what management do we have, we must not forget about this at any stage. And I'll keep emphasizing that for the interest of the audience. So with so much diabetes, with risk factors, which we said this is modifiable, but we just are not able to cope that. There are a lot of deaths. And that's the worrying part as well. Where does the higher prevalence is and where is all these deaths? Unfortunately, it's in the middle and lower income countries. And the worrying part is that things are not changing. This is current and it is not changing in 2050. So we've got a high prevalence, we've got a high rate of deaths, and we will continue to see in lower and middle um, income countries in the days to come, and Pakistan comes in the parameter of those countries. So we all know that. What is the problem? I think majority of our primary care physicians treat diabetes pretty well. But this is a figure from US and foreign countries where all the facilities for support services to diabetes care is available. And look at the number of percent of patients for the three goals: A1C, blood pressure less than 140/90, and LDL. The number is only 25% who achieve all these three goals. But if you look at diabetes, less than 50% of patients achieve the goal. In case of Pakistan, it's around 30%. That 30% of our patients achieve the goal, what is noted for them or what is prescribed for them. The other bigger part is that it takes time to intensify treatment. Does the guideline say that? We all know, no, it doesn't say that. But it takes 2.9 years for time to investigate, which is a delay after A1C exceeds the threshold. And one of the way which we can overcome all this is give a combination therapy, which again is a very little number of patients who achieve or who receive combination therapy to achieve the goals, at least for A1C. Forget about the blood pressure. One of the better things for blood pressure control now is I hardly see people on a single drug as an antihypertensive therapy, particularly in diabetes. And one of the reason is that there's a lot of combinations now available, 2 combination, 3 combination for blood pressure. And that's why we are getting a good results as far as the blood pressure is concerned, because you have 2 or 3 drugs in one pill, and that makes life easier for the patient. For diabetes, this may not be true, but it is true, and I'll intensify and I'll talk about that in a minute. So there is a clinical inertia. Is there a science or evidence behind it? This is the evidence. I don't know at the back you're able to see, but it's a large data from 2017 to 2018, 58,000 subjects, A1C more than 8% after exclusions, the numbers, so on and so forth. And a final cohort of 518 patients in the primary care physicians settings were selected. And what did they find? They found that intensification is lesser if the A1C is around 9 or thereabout. And it's better if the A1C is more than 9. So the general physician would intensify, the higher the A1C, they will intensify the treatment quickly. But once they come to around a figure of 9, the setup or the urgency disappears in primary care physician. Patients with the highest baseline hyperglycemia are likely to receive third anti-diabetic agent. So the higher the A1C, they will go aggressive for them. But once it touches 9, and you and I all know that 9 is not the figure we'll be shooting for. We want to shoot it lesser. And one of the reasons for shooting lesser is because as a South Asian, our risks are much higher compared to the Caucasians. And in that study, again, they found that 4-month delay in the intensity of management. This shows that the time for treatment intensification by baselines, again, 9%, and post-intensification, both the group shows improvement. But of course, the more you intensify, the better the outcome will be in terms of A1C. What does the current guideline say? Particularly the American Diabetes Association, because that's a champion organization. They say reassessment of therapy after 3 to 6 months, early combination therapy when appropriate, prompt treatment intensification if targets are not met, and use of agent with cardiovascular and renal benefit. This is something new, and I thought I'll touch on that. I think one of the major other element, the treatment given by American Diabetes and Europe ESD, that prompt treatment in investigation if targets are not met. This statement is very important. And I think this is important for people on oral therapy. This treatment, this statement is important, particularly for people even on injectable therapy. You cannot say that I've started patient on insulin and the patient would say, I'm on insulin, I'm still not controlled. But the downside of that is that people start on insulin, people start on treatment, but they don't intensify the treatment. And I think that's where, in our setting, it gets lesser role, and we need to ensure that the proper intensification is done. Is there a benefit of early intensification? Yes, of course it is. Because if you have a different mode of actions of treatment for a single patient, you know, you and I know, and I'll touch that in a minute as well, that now we know that in our medical school days, I remember I'm talking about 80s when we were studying medical school, there was just one thing. There is insulin resistance and there is relative insulin deficiency. This was the statements which was taught to us. But now we know it's more than that, because there are multiple disease mechanisms which preserves or prevents the complications, multiple pathophysiological defects, insulin resistance, secretion, hepatic glucose output, beta cell function. And so if you've got a combination, the likelihood is, as is with and I keep on referring to antihypertensive therapy, that if you combine the two drugs at a lower dose, the likelihood of the side effects is going to be lesser for patients who using combination than using a single therapy alone. So at a lower dose, fewer side effects. Of course, if your patient is well controlled, it delays the insulin therapy. And I'm certainly not saying that we should not start insulin in patients who are insulinopenic. I'm not saying that. But what it means is that patients are reluctant usually to use insulin. So if they are reluctant, you are delaying the insulin therapy by getting a control with the multiple drugs. And of course, it prevents long-term complications. So how does the early combination therapy look like? Now, if you look at the 2026 diabetes management, and this was the old approach where you would start lifestyle, then metformin, then dual therapy, then triple therapy, and then finally insulin. But now the newer approach is slightly different. And what it does say in many guidelines, and I'll touch that in a minute, is that you need to concentrate on cardio-renal protection. And come back to that figure what I earlier told you, that 27% of our patients are undiagnosed. As a result, primary care physician sees the patient with a complication when they are newly diagnosed. And that's where I think our setting comes in. That because you're not seeing in the Western society where the people are screened and they come by the primary care physician and they have a regular checkup. We're not talking. Let's talk real. And the real thing is that they are seen with a complication. And that's what we need to look at. So the newer approach, the new guideline says that you need to have a goal to have a cardiac renal protection, and your treatment strategy should be metformin plus SGLT2 if you're looking at that, or if your patient is presenting with some sort of complications to begin with. We know that micro and macrovascular complication is a burden. And I again say that undiagnosed. So when you are diagnosed, you're likely to have any of these complications at the diagnosis. And that tells us that our management is not simple lifestyle and it's not simple metformin. We need to have two drugs to begin with. You would say, we all know that. Whatever I have told you, you all know that. So where's the problem? Let's look at the multi-organ dysfunction. Now, not any talk will go without GLP-based therapy. Any talk on diabetes, it will not go without it. So we agree with that. The insulin resistance, the muscle, the renal hemostasis, the neurotransmitter defects, hepatic glucagon, insulin secretion, all these are what they call ominous octet. All these are the multi-organ dysfunction. So the old saying that there's insulin resistance and then there's insulin deficiency, it doesn't hold anymore. Now there's a lot of problems in a person with diabetes. And on top of it comes cardiovascular kidney metabolic syndrome, where the kidney, heart, and pancreas are all affected. And you add on to that obesity, that gives the picture a very grim outcome. And I think one of the management should be concentrating on all these factors which are part of it. So cardiovascular complications, I don't know, again, you may not be very clearly looking, but this is the 8 guidelines, ACE guidelines. And what it shows is that when you select the therapy, you would look at the complication that patient have and then choose the drug accordingly. So if you look at, in this case, the heart failure, you will obviously choose a drug which affects the diabetes and it affects the heart, and that's SGLT2 and a GLP receptor agonist or a GLP-based therapy. Kidney disease, SGLT2 and GLP. Atherosclerotic cardiovascular disease, GLP, and possibly SGLT2s and so on. Strokes, GLP, and pipeline. So depending on what complications you have, at the beginning, you will choose your drug accordingly. So far, so good. We have a problem related to diabetes, high prevalence, high death rate. People are coming with a complication. And we all know that a good control is better. So what is preventing us from achieving this good control? We didn't know that until now when we had an access to CGMs. And here we found out that people, when we intensify the treatment, they end up in a hypos. And sometimes it's just not obvious. And in older people, it's even worse. So one of the fear for a primary care physician, I'm sure, is that I don't want to benefit him, or I don't want to deny him of the benefit, but I don't want to harm him. And one of the reason is I don't want a hypoglycemia. That's a genuine worry. So any treatment which doesn't cause hypoglycemia, I think from the perspective of general practice, would be welcome. This is again the CGM of hypoglycemia in older, and look at the time they spend in hypoglycemia on the treatment which causes it. So sulfonyl-based treatments or insulin, it will cause hypoglycemia. So any treatment which is not sulfonylurea or insulin-based will cause lesser hypoglycemia. And I think this is not imaginary thing. This is the science, and this only we found out when we started looking at the CGMs, and this is where the benefit of the new technologies. CGM used to be used in type 1 diabetes only, but now it's widely used and it is available. And I think with the days to come, the cost of the CGM is going to keep on coming down, and we'll have a more insight of what to use, when to use, and what is the outcome of the CGMs in this patient. This is again a busy slide, but what I'm trying to show here is that use of CGM in type 1, even in pre-diabetes, in metabolic dysfunction, gestational diabetes, a big yes for using a CGM to get a better outcome, muscled, and so on and so forth. So CGM is coming very fast to us, and I will urge my primary care physicians to use it, to learn it. If nothing else works, the CGM will tell you what lifestyle made benefit for the patient. So hypoglycemia, as I said, is one factor which prevents us from titrating the medicine. The principles of adult type 2 diabetes management, lifestyle and is the foundation of all. I keep on saying choice of pharmacological therapy. Choice of therapy considers ease and use of access and for our patients. Individualized targets, we know that. But I think 2 points I will stress upon. Avoid hypoglycemia if you want to manage. And avoid therapeutic inertia. And the next thing which comes is concentrate on a weight loss. So any management for type 2 diabetes, majority of our type 2 diabetes patients are obese. So any management which gives a weight loss will be welcome. You would agree with that. So any management which gives a weight gain to already insulin resistant patient is a big no-no. So now the diabetes care of 2026 is got a new philosophy that you have your own care goals for individual patients. You look beyond glucopenic effect, which is kidney, heart, and liver. And then weight management is the core of therapy. So any management which causes weight loss would be welcome. And of course, the other things which adds to this. And again, this is management that we need to look at drugs which cause less hypoglycemia. There's a lot of drugs which are available to us. We are living in times where the benefit of many drugs with many actions is available to us, and metformin, GLP-based therapies, SGLT2, so on and so forth. And you need to choose between them what works on weight. And we know there are a lot of drugs which are either weight neutral or actually cause a weight loss. The protection of kidneys, SGLT2, GLP receptor agonist, metformin plus minus. In fact, if there's a renal dysfunction or EGFR is less, you need to avoid that. And the side effect profile and work on liver. So you need to choose between these drugs, how you go about. Again, American Diabetes Association Careway Pathway, looking at what you want to choose based on what complications patients have, and this would be your choice of treatment to begin with. So there are a lot of champion organizations in the world, starting from ADA, ESD, NICE, ACE, so on and so forth. And what they all recommend in first line, if you've got a complication set in, that you need to use 2 drugs minimum if you want to achieve the target quickly. The only organization which still sticks to metformin only to begin with and then add SGLT2 is the IDF. And you and I know that IDF looks for a global perspective for the resource-constrained countries, and that's why they stick to that metformin to begin with. But then, of course, when the situation doesn't help the patient, they can choose the other management depending on what is available to them in those resource-constrained countries. So, this is all new, that you need to use combination therapy. So, is newer always good? Is newer always needed? And most importantly, is newer always right? And back in my training days, whenever the word always comes, you've got to be doubtful. And that's why you need to individualize the treatment. So a newer management, a newer course of therapy, a newer always can't be right. You have to choose wisely for what patients you are choosing, what is your patient, what is their comorbids, and how you want to deal with that. So, yes, I would rephrase it. Is newer treatment better? Is newer needed? Is newer right? I'll exclude the word always there. And the reason is that you need to take care of all these metabolic abnormalities that the patient have. So what drugs do we have which would address majority of these metabolic abnormalities? We have metformin, which takes care of one of the additional benefit over hypoglycemia, which is the liver. Then we have got a SGLT2. Then we have got DPP4s. We have got TCDs and insulins. Insulin is injectable for the sake of discussion. I'll exclude that. But if you look at these three drugs, they will target majority of your metabolic consequences or metabolic abnormalities, and these three drugs stands out on their own. SGLT2s, particularly empagliflozin, has got a very robust data, both on cardiovascular. We know the data come from EMPA-REG, where the benefit was there over and above placebo. And we have EMPA-REDUCE for the cardiac benefit. Risk reduction was better in compared to placebo. And then we have empagliflozin on preserve reduction, and again EMPEROR trial shows the benefit over and above. So a part of a combination which we recommend, empagliflozin has a good cardiac and renal outcome better. The Carmelina trial was on linagliptin versus placebo, and 3-point ACE was non-inferior, and after 12 weeks of treatment, mean difference, there was an improvement. Again, compared to glimepiride, and one of the reason why we don't want to use sulfonyl-based therapy is the risk of hypoglycemia, and that stands out. So, combination of empagliflozin, linagliptin, in inadequately controlled type 2 diabetes who are on metformin has shown benefit, and the patients achieve A1C targets over 24 weeks much better compared to the single drug which is used to that. I've got last two slides. I don't want to go into this, but I want you to concentrate here. What changes in the real visits? Target and medication to real life, not ideal. There's no ideal treatment for anybody. It has to be real life. What is better for my patient? CGM, right tool, better onboarding, reduce the frustration. So you ask the patient, get him on board that what I'm doing and what I'm not. It's not the BMI and weight, it's the whole body composition. You need to have, as mentioned yesterday by Aisha, the SMART goals, the realistic, measurable goals. Choose agent that based on the whole person. Align the glucose, weight, liver goals, and the fibrosis risk. Intensify the treatment. Avoid the over-therapy in old and fragile patients. Therapy to protect kidneys, treat the barriers, and simplify the plans and reduce the hypoglycemia. And one of the way to simplify the plan would be reduce the pill load of our patients who comes to us with many other comorbids. I finish my talk here, and thank you very much for your patient listening.
Thank you so much, sir, for your excellent talk. Now it's the time for the question answer. And due to the shortage of time, we can take only 2 questions from the audience. So if there is any question.
Either all was very good or all was very bad.
So there is a question.
Yes.
Please give him the mic.
So much, Professor Jamil for an always enlightening talk. I really appreciate because, as you mentioned, we may be knowing many things, but you made us, you like how we can use these guidelines, how we can use effectively guidelines in the primary management. My question is that you showed that there is 36% hypoglycemia in the old age, even when they are not on insulin and sulfonylurea. So what can be the cause of their hypoglycemia in those patients?
I think it's a very obviously important question. Generally, old age, there are many comorbids attached to it. Their mobility, their timing of eating, how often they eat, and particularly if they are on sulfonylurea or based therapies, that makes livelihood at even a lesser dose. One thing which I question always, and I think time will tell, that if somebody is controlled on 1 milligram of any drug or a smaller dose, does the higher dose make that much of a difference? And I think that becomes very pertinent to our old age patients who are frail. Their meal timing may not be adequate, and then they may have other comorbids which will make them prone for hypoglycemia apart from the sulfonyl based treatments. Right.
Thank you, sir, for detailed presentation. Just my question is, sir, where you will place the pioglitazone, particularly in a young obese patient with MSLD? It's still we are avoiding pioglitazone we can use in such a patient.
You said you, so I will answer as me. I don't like glitazone. As simple as that. And those of you who are trained with me, those of you who see my practice, I hardly use pioglitazone now. But yes, there's a small benefit. Yes, we know that. But whether that benefits for patients in what way, and if particularly if they are obese and if they are on other treatments, which will cause further weight gain, I'm not very comfortable with that. And I would rather avoid that. And as I said, it's me. It may be other people who would still use it. Thank you.
Thank you so much, sir. Now it's the time to take the valuable comments of our panelists.
Assalamu alaikum, everyone, and thank you, Dr. Aamir, for such a comprehensive overview on diabetes management. Diabetes is definitely a condition that has evolved rapidly over the past decade, particularly. And now we have to really teach our primary care physicians, and we have been doing that. What's important is that we continuously hold CMEs, continued medical education programs such as these, on a regular basis, hold short courses, maybe 3 to 6 months courses, online hybrid courses for them, because they're also very busy. Everyone's busy, that they can, log in at their convenience and try to gather as much new knowledge that is out there. Plus also, didactic lectures are important in their own right. Case-based scenarios are very important. Like this gentleman asked about the use of pioglitazone. There are situations where it can be very, very helpful. Now we have drugs such as SGLT2 inhibitors, GLP-1 receptor agonists. Combining them with the pioglitazone may be able to may allow us to mitigate the side effects and accrue the benefits of all those agents. So yes, that's important. And I'm really glad that the Pakistan Endocrine Society has been regularly holding such CMEs, and we've been trying to educate our primary care physicians to keep them updated abreast on the rapidly evolving diabetes realm. Thank you so very much.
Bismillahirrahmanirrahim. Good morning to everyone. Thank you very much, Nabi Qasim. Thank you, Dr. Yaqub Khan and Tahir Khan for organizing such an excellent conference and kind invitation. Thank you very much, Sir Professor H. Aamir Saab, for an excellent talk as always, and a very important and a relevant topic. As we all know very well, the number of people with diabetes are increasing day by day, and we are failed to control the prevalence of diabetes as well as reduce the complication of diabetes despite we have multiple options of medications, updated knowledge. The reason behind this is we are living in a sick care model, so we have to move forward to the healthcare model. That is very important, although it is not an easy task, but it can be doable. So we all know the primary care physicians are our backbone of our health system. They should not only focus to control the glycemia, they have to focus on the healthy lifestyle. Most of our primary care physicians, even they are not aware what are the healthy lifestyles. For healthy lifestyles, they have to give to time to the patient regarding the healthy eating patterns, regular physical activity. Even they have to focus on adequate sleep, stress management, avoidance of risky substance, and there is also a strong need to build the patient's emotional and social support. If we train our primary care physicians, we can reduce the diabetes complications. We have to good glycemic control. Even we aid the health span of our patients. Most of the time, our objective to improve the lifespan of the patient, the most important thing is rather we have to focus on the lifespan, we have to improve the health span of the patient. Thank you very much.
Thank you, Professor Aamir, for an excellent talk. I think no better time than the beginning of a conference to emphasize the importance of primary care and diabetes management. Other than that, I think one of the most important take-home messages is to take care of how to overcome the clinical inertia, especially in an era where we have so many diabetes drugs available that never before has we have been able to achieve targets as easily as we can do now. So thank you.
Thank you so much to you all, our worthy panelists, our speaker, for the participation. And now I'm concluding the session. The next session will be at 9 a.m., which will be moderated by Dr. Mavish Iftikhar. Thank you so much.